Thanks, Vardhaman. Thanks for including me in this wonderful session. So I'll be talking on managing a cataract in presence of uveitis. So you need to understand that unlike the other conditions which will be discussed in this session, that the outcome of a cataract surgery in uveitis depends on two things. One is how good is your pre-op treatment and how good is your post-op. I assume that all of you know how to do a cataract surgery, so I don't need to teach you about that. So I'll just try to break one myth with that if the eye is quiet for 3 months, then we can go ahead with surgery. So this is sometimes actually not true. I'll give you two case scenario. You see here, 128-year male complains of recurrent attacks of uveitis in past, HLA-B27 positive, last attack of uveitis 4 months back, so it's quiet for 3 months. And this here not on any systemic medicine, and here you can see a 61-year-old female, recurrent attacks of uveitis in the past, known case of VKH, last attack of uveitis 6 months back. So not on any systemic medication. So these are the patient, if you are going for a cataract surgery without any starting a medication or waiting for at least 2 to 3 months, you are definitely going to burn your finger. So this is very important to understand. So before you touch a uveitic eye, you need to understand the three important points. So the first, number one, is that identify the etiology of uveitis. If it is a case of Fuchs uveitis, if it is a toxoplasma, white dot syndrome, go ahead. Directly you can go ahead with a steroid cover of 4 to 5 days. But if you are dealing with juvenile idiopathic arthritis, HLA-B27 associated uveitis, Vogt-Koyanagi-Harada disease, idiopathic anterior uveitis, or tubercular sarcoid uveitis, or viral anterior uveitis, then you have to be very, very careful, because these are the entity are known to have a recurrent attack of uveitis even after the cataract surgery. So you have to be very, very careful. Second important is understand that whether the patient is on any effective immunosuppression for a sufficient amount of time. This is very important, that effective immunosuppression. It doesn't mean that the patient is on 5 mg oral steroid or for 5 days. So effective immunosuppressions for a sufficient amount of time is the key here. The third one, beware of two clinical signs. One is extensive posterior synechia. These are the patients with high risk of postoperative inflammation, including CME. And second is that macular edema. So if there is a history of macular edema, the severe it can have a severe post-op inflammation and can have greater risk of macular damage also. So management of synechia, I just want to highlight that occlusio pupillae, you have to understand that whereas sometimes the fibrotic membrane will cover the pupil. So sometimes this membrane is so tough that you can't break it even with any instrument. So here in cases, if the patient is having any PI, sometimes you can use the PI to inject the viscoelastic, which will leave the iris little away from the lens, and actually you can take a 26 gauge needle, as I have done in here, and you can actually prick and go make a opening into that fibrotic membrane. And second important thing is that the peripheral anterior synechia, you have to make a room for, as you can see in this case, you have to make an entry for that, but don't go and try to make a wide dissection of this membranes, because sometimes it can actually lead to the Descemet's membrane detachment also. So try to do minimal separation, try viscoelastic to use that, and if it is not working, then you can take a spatula and try to dissect it. So management of small pupil, many of you know, because you in your routine case also you handle a lot of other small pupil cases, but there are so many devices available. I won't go into the details of that, but sometimes you have to understand that the large pupillary membranes can be incised with the microvitrectomy scissor and can be stripped from the pupillary margin before you put that. So as you can see this case here, so sometimes it's important to dissect the membrane before you apply the ring in uveitis. And coming to that, there are so many options. If you want to use the Coughlin hook, you have to remember that if the pupil is very small, then it works better, because the smaller the pupil, better will be the dilatation outcome with the Coughlin hook, and better to avoid the Coughlin hook in eyes with very, very shallow anterior chamber, because you can damage the endothelium accidentally. So Grisherver hooks are much better. It's a very good instrument for that, but only one word of caution, that don't avoid placing these hooks very anteriorly in the cornea, because it can actually lead to the tenting of the iris tissue, and which can actually be damaged while entering into the eye with the phacoprobe. So coming to the rhexis, again just 2 points I want to highlight. Avoid very small rhexis, because in uveitic eyes are notorious to develop the capsular phimosis. So be careful that, and also don't try to avoid the very large or eccentric rhexis in cataract surgery in a patients with uveitis. Why? I'll show you here. These are the cases I'll be showing. These are all in the bag lens implantation. You can see that IOL has been placed in bag, but you can see here with that UBM is showing, because it's a large eccentric rhexis, the square edge of the IOL is actually touching the iris. So whenever there is it's touching the iris, so it is causing a subclinical inflammation, and the patient is developing the inflammation. I'll show, you can see my the schematic diagram where I have tried to show that how the square edge can actually rub the iris. So similarly, this is another case you see here. This is a large rhexis, eccentric rhexis, and with a jonular laxity, and you can see that IOL has popped up little and causing significant inflammation. And also you have to understand, when you are using Grisherver hooks, sometimes you check thoroughly that whether you have missed any cortical piece or anything, because sometimes the Grisherver hook, they causes the tenting of the iris, and small piece of cortical piece or the epinucleus segment can be actually lodged underneath the iris. So you can see here there is a small piece lying there, and it was a cause of inflammation after the surgery. And you can see here another, the retained lens fragment. So also in uveitis patient, try to actually always use the better quality of lens. See, this patient of uveitis came to us with complete opacification of the IOL. So we explanted this IOL. I don't have any financial or anything, but I just want to show you this, that this IOL, when we took out, we could see some sediment. So what we did, we just took the this IOL material for the electron microscopy picture, and you can see that electron microscopy is showing, this is, you can see, is the inflammatory cell, clump of inflammatory cells. It's actually eroding the lens surface. So if you using poor quality of lens, the inflammatory cells can actually invade the lens material and actually cause complete opacification. So always try to go for the ideal and good quality lens. And also we have we are doing routinely the cataract surgery in scleritis patient. So sometimes the myth is that in scleritis you should not use scleral incision, but sometimes you are like such cases, no, where you have 360-degree corneal thinning and all. So sometimes if your control of the scleral inflammation is adequate, you can actually go for scleral tunnel in these patients where the is not possible. So sometimes you have to be very careful. Not necessarily every patient will require. This is one of our patient. We are thinking whether we'll go for patch graft or not. But finally, we could do the surgery. You can see here without doing patch graft and all, the patient is doing well. And you can see that after that, in scleritis patients, sometimes you need to take a suture, because the rigidity of the eyeball is so less. Sometimes you can't rely on that. So you need to take that. So if your control of the scleritis is perfect, don't worry about taking suture and all in such patients. This is again coming to, I'll just touch one point of pediatric uveitis. This is just to show that this patient has been treated with 1 year actually with adalimumab and methotrexate for GIA. So you can say that the child was treated adequately for immunosuppressive. Then I did the cataract surgery, and see, one eye the child tolerated the IOL very well, and other eye we need to explant the IOL. So one thing to remember, that no rule fits all the eye. You have to take an individual decision. So prevent IOL in children with uveitis in following condition: if the AC is very shallow, if there is severe history of inflammation, hypotony, age less than 4 years, don't try to put IOL in children. And also one word of caution for the pediatric ophthalmologists who, after doing cataract surgery, they do a posterior capsulorhexis and do extensive vitrectomy. You have to remember that in children, if there is a vitreitis, then if you do extensive vitrectomy, it can actually cause a traction and cause subsequent retinal detachment. So don't do that. So just to conclude my talk, as is your pre and post-op immunosuppression, so is your outcome in cataract surgery in uveitis. Extensive posterior synechia and macular edema are two important clinical signs that should alert you before cataract surgery. Scleral incision can be used in certain conditions like peripheral ulcerative keratitis and necrotizing scleritis. Large eccentric rhexis can be a rare cause of post-op inflammation, so better to avoid that. And no rule that fits all eyes in pediatric uveitic cataract. Thank you.
Yeah. Wonderful, absolutely. Very, very nice presentation and beautiful pearls shared, Dr. Partho. Quick comments from Dr. Harshul and Dr. Armiya about uveitic patients with cataract.
Uh, that was a very nice talk, Dr. Partho. I think what has made our life very easy as a cataract surgeon is the invent of this pupillary expander. So now, whatever is the size of pupil or whatever, how much fibrotic it is, how much small it is, with the like malignant ring is my preferred device. I love to use that device, and I can put in very small pupil also. So I think that makes our surgery very simple. And he rightly said that it's not the surgery. Surgery has become very simple with these categories. Release synechias, put ring, and everything becomes easier. But to control inflammation is the key. Like in folks, and those are straight away forward cases, they don't have any problem. But those cases who have chronic inflammation, they need to be medically controlled well if you want to have a good results. That's my take.
Thank you for very much for the presentation. Just to highlight that uveitis is like glaucoma patients. Pre-operative and post-operative is more important than like the intraoperative procedure, because you can do a very nice surgery, and second day or the first week, if you didn't control the patient well, everything will back to level 0. So post-operative control and meticulous close follow-ups for the patients and also for the parents, because sometimes in pediatric uveitis the patients are not aware of what is the problem. So if they missing the drops or even the follow-ups, the complication will start, and in a month everything back to 0. So this is very important, that managing the patient and the relatives is the same important as pre-operative and intraoperative.
Yeah. Thank you very much. And thank you again, Dr. Partho, for